Hello, good morning to everyone. Thanks, thanks very much for to the organizers for having me giving this talk about neuroblastoma. Is it one disease or many diseases? It is a pleasure to be here, and I can only agree with Dr. Evans in her quotes. This introductory talk, I think it's quite challenging trying to cover or trying to show how heterogeneous neuroblastoma can be, and I try to give an overview of everything that we know or where we are doing research in terms of neuroblastoma biology, of why is it so heterogeneous, and trying to touch in every aspect that we are studying of this disease. It is truly very heterogeneous, and we will start. You all know that it was initially described by Virchow, a German pathologist, back in 1864, and then the name was given by Wright. That's Professor Virchow in his lab, and it is a tumor of the neural crest that arises in sympathetic nerve ganglia that can arise in different locations. So neuroblastoma is not a brain tumor, despite its name. And it usually arises in the adrenal glands, in the abdomen, in the thorax, but it can also can occur in neck and pelvis. So when several decades ago the doctors started recognizing neuroblastoma, the first thing that they realized, as for many other tumors, is that it can be relatively localized or widespread. And that's where the first staging for neuroblastoma in stage 1, 2, 3, and 4 became apparent. So being stage 1, very small, stage 2, bigger tumor, stage 3, larger tumor, and stage 4 when it was metastatic. That is quite common to adult and pediatric tumors. But then they started realizing that there were specific aspects of neuroblastoma that made that typical staging of localized, small, and big, and then metastatic were different in neuroblastoma. In the majority of adult oncology, that's how you classify the patients, and that's how you decide the treatment. If it's localized, you operate on it or give local. If it's localized but is big, you give local treatment. And if it's metastatic, you give chemotherapy. That very simple approach will not apply to neuroblastoma. First, here we are. First, because there are three different phenotypes, three different behaviors that are relatively independent of this 1, 2, 3 staging system. So, for example, there are what was called stage 4S neuroblastoma, S for special. It's called now MS for metastatic but special. And these are infants with widespread metastatic disease, particularly in the liver or skin, whose disease, with no treatment, it will just regress. Or sometimes they're sick at the beginning and they need some treatment, but they do not need all the treatment that patients with stage 4, the other metastatic patients need. It just disappears. You do nothing and it does disappear, and that was quite striking. The second situation is also, this is called, in medical terms, a gigantic neuroblastoma. It is a neuroblastoma that happens in the abdomen, besides the liver, but it goes all the way on the side of the spine up to the neck. So this huge tumor, it's inoperable, but actually this patient, being an infant, it did need very, very minimal treatment. The tumor stayed as it is, no changes, did not respond, but did not progress, and the patient is well decades after that. So that's again another striking situation for other types of cancers. And then obviously there are metastatic neuroblastomas with widespread disease that do behave very aggressively and poorly. And then after this discrepancy in the typical staging system, the clinicians back in the 80s realized that there was an oncogene, a gene called MYC-N, or NMYC at the beginning, that is amplified, and amplified means that we usually have 2 copies of every gene in every cell of our body, and for this gene there were a lot of copies. There are more than 10 copies in every cell, and that is associated with very poor outcome. Particularly, for example, in groups that would do very well without MECAN amplification. For example, infants, they would do poorly if they have MECAN amplification. So this is the survival curve, as Juliet was explaining before. If you don't have amplification and have an infant neuroblastoma, the vast majority of the patients, that's 80 or 90% of the patients, will survive. Whereas if you have got MECAN amplification with the treatment back in the 80s or 90s, your survival is low, it's about 10%. And that led to the concept of risk groups based on clinical and biological factors. And that is, we do not give the patients treatment according to their stage, 1, 2, 3, 4 status, but we incorporate many other variables in treating the patients. And that leads to this classification that again Juliet was mentioning. There are low risk and very low risk patients, and they do need minimal treatment, if any. There are patients with intermediate risk that get surgery, chemotherapy, sometimes radiotherapy, but again the outcomes are generally are good. They're not as good as low risk patients, but they're good. And then high-risk patients, which are those with metastatic disease or those with MECAN amplification, where, again, the outcome is worse and they need much intensified treatment. But that's, so all this heterogeneity in the same tumor leads us to ask, why is that? What is the biology of the tumor? What are the causes of the neuroblastoma? And here is the biological perspective. The short answer to the initial question is that we don't know. Still, we don't know why some tumors just stay as they are. Some tumors differentiate and mature. Some tumors just disappear. And some others relapse and relapse and relapse. And some others are very aggressive and very rapid. We just don't know. Every year we know more and more about the biology, and we know better how to treat them. But still, there are a lot of questions to answer. So we need to do this research into the biology of neuroblastoma, because we need to know the causes of neuroblastoma, if there are any causes that can be avoided. We need to understand the mechanisms of neuroblastoma initiation. We need to know the biology of that makes the behavior to be aggressive or more benign. We need to identify, this will help to identify new targets to develop new therapies. And also we need to study biomarkers, which are just biological characteristics that will make us give some patients more treatment and some others less treatment or different treatments. That's again a concept that needs refining. This low risk, intermediate risk, and high risk is still not a perfect classification. And there are patients that are called intermediate risk that should have been high risk, and vice versa. And that those that have a better biologically less aggressive disease should get less treatment to have less problems in the long term, and those that have higher chances of relapse should get all forms of therapy that we think are necessary. So these are the aspects I'll touch on. It is aimed to be an overview of where we started a few years ago, trying to identify these causes for and understand neuroblastoma biology, but is by no means a comprehensive or systematic review. Oops. So, as well as all these aspects that we've tried to understand in neuroblastoma biology, initially the two-hit model of cancer development, genomic changes, a genetic and initial genetic model, molecular profiling, the neuroblastoma stem cell, microenvironment, immune therapy or immune environment, and telomeres and epigenetics. This has paralleled a bit the revolutions in adult cancer, and in particular in adult cancer drug development. We know about molecular profiling from the time of when molecular targets were started to be studied in other cancers. This is the paradigm of personalized medicine, where you would ideally find a perfect drug or a perfect combination of drugs for each different patient according to their molecular and biological characteristics. There's recently been a revolution with immunotherapy, and even more recently another revolution with epigenetic therapies. So we're trying to apply all this knowledge to neuroblastoma, to understanding neuroblastoma biology. Back in the 80s, the two-hit model of Knudsen is one of the first models to try to understand why neuroblastoma happened. And the first hypothesis is that up to Knudsen and Strong thought that up to 20% of all neuroblastomas could be the result of a germinal mutation. So you had one mutation in all your cells that you inherited, and then you got a second mutation, and that second mutation that you acquired during early life is what causes the neuroblastoma. You need to have the two genes mutated to develop the disease. You inherit one, and then you get a second one during your short lifetime, and that causes the cancer. That was applied to, that worked for other cancer types, but this model does not apply to the majority of neuroblastomas. There's only 1 to 2% of neuroblastomas that are actually hereditary, we know. Back in 2008, the Philadelphia group identified several families where there were cases of neuroblastoma in different generations, and they identified that there were ALK mutations, and ALK is the most common cause of hereditary neuroblastoma. And this graph tries to show that there are other aberrations, but have either low penetrance, so they do not occur very often, or they do not have a big impact in the disease. So actually, ALK and FOX2B are the major causes of genetic hereditary neuroblastoma, but that can only explain a very small proportion of cases. Then the researchers worldwide started to study the genome, the genes in neuroblastoma. And there are different levels of complexity as the technology has been improving. So first, ploidy is the total number of chromosomes. So you do know that we've got 23 pairs of chromosomes in every cell. That makes up 46 chromosomes. So there are neuroblastomas that have these, the normal number of chromosomes, and that they're called 2n, but there are others that have 3n or 4n. They have 50% or double the number of chromosomes in all of all the chromosomes. But when you start looking at in more detail, there are other neuroblastomas that have numerical chromosomal aberrations. So they've got their 23 pairs of chromosomes in the neuroblastoma cells, but for one chromosome, there are more than 2 copies. There are 3 or 4, or for a couple of chromosomes. When you look in more depth, there are segmental chromosomal aberrations. So that's not the whole chromosome, but a part of it is missing or is gained. There are some common aberrations that there are still in clinical reports, 1p, 17q, 11q. That means the part of the chromosome that is missing or that is gained, that is not there. And each of those hits, they did have a prognostic implication. So you could identify some of these led into a better outcome, some of these led into worse outcome. There's innumerable, the number of factors that can affect outcome in neuroblastoma. What we are missing is an integrated approach that takes them all into account. Some of them are redundant and some of them aren't, but still we don't have a perfect system to get together all the prognostic factors. There is MECAN amplification, so that's not at the chromosome level, but at the gene level. You should have 2 copies of MECAN. Patients with MECAN amplification have more than 10. And finally, in recent years, mutations have been identified. There were studies looking at all the genome of neuroblastoma, and then identified that in some cases, the sequence of the nucleotides there is a change, there is a mutation that leads to a different amino acid, and this is where there are mutations of ALK or P53 or RAS, for example. at the beginning with the ploidy, this is one of the first models of how which would explain why neuroblastoma was so heterogeneous. And this relied on the ploidy, on the absolute number of chromosomes that you had, whether you had more or less, and in TRAC, which is a transcription factor. So you could have, and this model developed by the Philadelphia group that you can nicely read in this review, you could have triploid tumors or triploid and tetraploid tumors, and depending on the expression of TRAC, whether that was TRAC-A or TRAC-B, or the different alterations in the chromosomes, the 11q, 14, 17q, you did get different types of neuroblastomas, one that went into differentiation. So these are the tumors that do not regress but do not progress either, that stay the same. You would get apoptotic cells, so the cells will die and disappear, and then the more aggressive ones with some of the aberrations or mecan amplification. So the initial hypothesis was based on TRAC and ploidy. Then we got to molecular profiling. So the study is done in the US and in Europe, trying to sequence the whole genome, identified relatively few mutations in neuroblastoma. There are some more mutations at the time of relapse, but still there are not that many. The paradigm that you could find a mutation in every tumor and then find a drug for that mutation is not a complete reality still today. And the number of genomic aberrations is still, they're relatively not very frequent, and not all of them have a drug that can work. There are different sequencing programs running in the UK, in Europe, and in the US, and open trials for these targeted drugs. And we will see how this matching the genomic aberrations with the patient's treatment works in a few years' time. But also, more research has gone into identifying the hallmarks of cancer. The tumors have different vulnerabilities, and that's Hanahan and Weinberg described them a few years ago and then revised them back in 2011. And there are different ways to target these cancers. And different vulnerabilities, different Achilles heels for the tumors. And we should try to tackle as many of them. It's not just going to one alteration. The tumor has a microenvironment. The tumor has mechanism to grow and keep growing. The tumor needs blood vessels. The tumor has mechanisms to repair its DNA. And if we manage to break this DNA repair mechanism, that's another way. There are different ways, different methods to attack neuroblastoma cells. And for example, this is one of the examples, is that inside the cells, there are cascades of proteins that one activates the other and then the other, and that makes the neuroblastoma cells grow continuously. And there are different ways to attack this. You can attack with PI3K inhibitors, can attack it with ALK inhibitors. You can attack the cell, the neuroblastoma cell, in different ways, and this combination of not only the classic treatments with chemotherapy, radiotherapy, transplant, etc., but trying to identify what are the Achilles heels of the tumors in the lab and then translating into the clinic. There's a lot of work ongoing here. Another part of this work has been trying to identify whether there are neuroblastoma stem cells. So this graph tries to show where and which cells the neuroblastoma develop, and that's an aspect of research called developmental biology. What is wrong in the neuroblasts when they are being developed to do their normal functions in the development of the embryo? What happens with these cells that makes them stay there for a few years and then turn into a neuroblastoma during childhood? And even going deeper into each of the neuroblastomas, you would think the hypothesis is that not all neuroblastoma cells are the same. There are some specific cells that are called neuroblastoma stem cells, which are the ones that are more immature and lead to the rest of the neuroblastomas. And when you give treatment, you get rid of all the neuroblastoma tumor cells, but the neuroblastoma stem cells are more resistant and cause relapse and resistance to therapy. So these are still hypotheses. These are still models on how to understand this biology of neuroblastoma. But it is another part of the research. Still, we don't know if this is true, if there is a neuroblastoma stem cell, and you treat that stem cell and you sort the problem. But it is another way of looking at the problem. Another aspect is the immune system and microenvironment. The tumors are not alone in the body. They're interacting. They're nested in a tissue. They need to, in order to do a metastasis, the cells need to grow in a different tissue, and they need to fight against our own immune system. Our immune system is prepared to destroy foreign things, strange things that start to grow. So that is why it is important to understand the why and how the immune system and the microenvironment interact with neuroblastoma. And there is research ongoing trying to address this, and this also has a therapeutic implication of trying to improve our response, our body's response to the tumor cells. And there are examples of NK cells, of myeloid cells, of different type of immune subpopulations, and different type of the extracellular matrix and the soft tissues where the neuroblastoma cells grow. And finally, that's yet another and the latest aspect that I will mention. Beyond looking, we've been looking at different aspects of neuroblastoma: the genes, the chromosomes, what happens inside the cell, the intracellular machinery, what happens outside the cell, the relations with the microenvironment and with the immune system. But there's yet another aspect with these telomeres and epigenetics, and that's the changes that do not happen in the genes, but do happen in how the DNA is folded and how the DNA is translated and is transcribed into proteins and the cell functions. And here's another hypothesis by the Fischer group in Germany, where the reason for this neuroblastoma heterogeneity relies on the telomere length, on the way. So in this model, low-risk patients will be triploid. They will have low or absent TERT expression, no telomere elongation, and this one will undergo spontaneous regression or differentiation. These tumors have no MECAN amplification, no TERT rearrangement, no ATRX mutations, and few segmental chromosomal aberrations with low mutation frequency. The model is trying to assemble all the different biologic features that we know into a new classification that can explain, into a new model that can explain this behavior. And on the other hand, the other half of neuroblastomas will be diploid, and they will include a group of patients with MECAN amplification that have high TERT mRNA expression and telomerase activity, another group of patients with no MECAN amplification but TERT rearrangements that are described in the genomes of these patients, or 11q deletion, which accounts for another 20-30% of these patients with high expression of TERT mRNA and telomerase activity, and another subgroup with no MECAN amplification, no TERT rearrangement, but ATRX mutations, with again have been described particularly in older patients, and these do not have high TERT expression, but they have alternative lengthening of telomeres. That's what ALT stands for. But anyway, all of these have active telomere maintenance, and this results in progression and aggressive tumor growth. So again, this is the most current model using epigenetics and the existing knowledge of neuroblastoma genetics, trying to explain why this behavior is so heterogeneous and why this happens. So this is the overview of the different ways we've been looking at this heterogeneity over the years, and where are we now, and how we look to the future. I think you will you'll hear many very good talks in the during today and tomorrow. I wanted to mention a couple of points. Realizing that when you prepare a talk for your future vision, you should look at your talk that you did 5 years ago to see exactly whether your predictions or your interpretation of the situation were any good or not. And I've started to do this quite a lot. I heard a presentation from Andy Pearson in Berlin, again trying to do it the same. What was he saying in his talks 5 years ago, and what was he saying in his talks 10 years ago, and even beyond, just to see if what we think now, how reliable is the interpretation of the situation that we make now. So I wanted to comment. This is an editorial from Ross Pinkerton. He was the head of pediatric oncology at Royal Marsden quite some years ago, and he wrote an editorial in 1990 with a few comments which are interesting because we do not write scientific papers now, and I wanted to mention as anecdotes. First, he starts saying the management of metastatic neuroblastoma brings out extremes of view in pediatric oncologists. There is black pessimism from those who feel that little or any progress has been made and question the value of more than gestural or palliative treatment. This is in contrast to the excessive zeal and optimism of others who enthusiastically publish premature reports of advances in survival. Another of his comments was, because of limited patient numbers, randomized studies, even on a national basis, are difficult. Large randomized American studies with minor variations in chemotherapy have consistently failed to show significant differences. With the more radical, high morbidity regimens, it is essential that randomized comparisons are designed. Relying on historical comparisons to support claims of improvements adds fuel to the cynic's viewpoint. And finally, he was making a point about the need to update neuroblastoma staging and response criteria that were published in 1993. And he said, without standardized staging and response criteria, comparison of results is difficult. And in a further 10 years, the cynics will remain cynics and the zealots. Not many of these, some of these comments will remain very valid today, some others won't. The most novel drug that he mentioned in his editorial was carboplatin. It's a brand new drug. It's great. It's much better than cisplatin. It's got some myelotoxicity, but many other favorable pharmacological properties. Actually, it's true that we use a lot of carboplatin in treating neuroblastoma now. He says, because there's no new drugs for neuroblastoma, the only thing that we can do is try to combine the existing drugs a bit better. And that has been an evolution over the 80s, 90s, and 2000, trying to find better regimens. Unfortunately, we've probably reached our maximum. We cannot do more permutations. We cannot improve what we achieve by more permutations of existing old drugs. He mentioned the potential role of high-dose chemotherapy. That was, again, another new thing back in the early 90s. He mentioned biological agents. He does mention interleukin-2, does not mention anti-GD2 antibodies, and also mentions the plans to test differentiating agents such as retinoic acid. This is 25 or nearly 30 years after that. Where are we now? And these are just a few examples. This is a group of people gathered by Andy Pearson talking about the international collaboration and how to make faster advancements in getting early clinical trials for neuroblastoma. This is an initially European, that is now being extended, approach to put together clinical researchers with basic scientists and the regulators, the people from the European Medicines Agency and pharmaceutical companies and patient advocates to be all together trying to see how we can accelerate the development of new drugs. And this, the two very specific aspects are these are the targets that should be prioritized. These are the drugs that should be prioritized. And if we're all there, the regulators, the pharmaceutical companies, the researchers, and the parents, we all agree, and we all agree on the same targets and drugs to be prioritized. That's hopefully one way to speed up the access to new drugs, that more drugs get into phase 1, get into phase 2 trials, and are tested for neuroblastoma. There's another, there are other examples. This is a brand new paper about a new molecular classification for to classify the patients into low risk, intermediate risk, and high risk. There are innumerable publications of new molecular classifications. I chose one because this one because it's very recent, and because it does say it can substitute the classic age, stage, and MECAN status in neuroblastoma risk assessment. So all these new technologies are evolving and have to be incorporated in in the way that we usually stratify our patients. You know about the INRG staging system and the INRG risk classification system. So all these systems have to be refined to make a more accurate classification. And again, that's another a mention of another group of work that is being done in Europe, based in the UK by Sue Burchill, with molecular monitoring with neuroblastoma mRNAs. There are different tools to better select, to improve how we better stratify the patients into these different risk categories. So I'll just conclude. I've seen my 5 minutes graph, but I'll just conclude. The future vision is not very precise, because I worry that I'll look at it in 5 years and it won't be very accurate. But it's clear that we need to have a better understanding of neuroblastoma biology, that we need to integrate molecular profiling into the routine of how we treat patients, and that helps take the decisions on how the patients are treated. We obviously need to incorporate molecular targeted therapies. We need to even explore further immunotherapy. It is already happening. We don't need to say there has to be more international collaboration. It is happening, but more and more is necessary because of the patient subgroups, because the understanding the neuroblastoma research, we need to be all together, and we need to break the current barriers and bottlenecks together. There's I always try to give a half message, because sure, these 20 slides summarize a lot of advances in the understanding of neuroblastoma biology, a lot of advances in clinical trials, but actually there's still a lot to do, as you all know. I'm trying not to be neither a pessimist or an optimist. There's a lot to do, and we need to be together doing it. So that's it. Thanks very much.